All right, so welcome back. Welcome back, my friends. Once again, we're going to be talking about some pathology in here, and I'm going to try to go through this relatively quickly because I don't want this presentation to be super long because people won't pay attention if it is. Anyways, and may not pay attention anyway, but that's all right. I enjoy doing these lectures even if it is to an empty classroom during these times of COVID. All right, so in 2018, and I'm looking forward to seeing in a couple of years when they show the leading causes of death in 2020. I want to see exactly where COVID ranks on here. So in 2018, this is the last information that's available on the CDC website. As you can see, heart disease is a pretty major killer. Now this is in the United States we're talking about. Out of the U.S. population, usually about 2.5 million people roughly die each year from various and sundry causes. And this is just the top 10. And as you can see, heart disease, cancer, those are big killers. Accidents, car accidents, falling off a building, whatever, 167,000. And then number 4, chronic lower respiratory disease, 159,000. This is basically like, pneumonia, bronchitis, emphysema, COPD, whatever. In other words, something happened to the person's lungs, tuberculosis, and their lungs got jacked up and they died from that. And then number 5 right here. Now this used to be like number 3, I think, but now it's number 5 is stroke, CVAs. That kills about 147,000 people a year. So, kind of a big contributor to the total death toll in the United States. So we're going to take a look at some things that can happen, to people's brains. Now, the CNS anatomy, the central nervous system, is composed of the brain and the spinal cord. Your sensory nerves that are out in your skin, your touch sensors that are in your hands and everywhere else, heat sensors, cold sensors, pain, itch, all those things, those are considered as peripheral nerves. And so we're not really going to be talking about that today. We may cover that some whenever we do our trauma unit. But for right now, we're just talking about the brain and the spinal cord. Now, if you're looking at somebody's brain, the cerebrum, that's the part of your brain that actually does the thinking. It also controls your motor, a lot of your sensory, auditory, all that stuff. Oh, Adobe Acrobat updated successfully. I guess that's good news. Okay, that's all controlled by the cerebrum. And the frontal part of your cerebrum is what controls what's called your executive functions. In other words, like if somebody jumps in front of you in the grocery store, your limbic system is probably going to want to smash them over the head with something and kick them to the curb. That's the animal aggression in you. Your frontal brain prevents you from doing that. People that have frontal brain injuries, a lot of times they don't have any, like emotional response control. And they'll get very, very angry at what we consider as being nothing. And it's because they don't have anything, or they'll just be cussing a blue streak in public. And it's because their brain doesn't have like a super ego. It doesn't have a lid on it, in other words. Now the cerebellum, back at the back of your brain, there's a couple of, basically looks like balls of spaghetti. Those are the 2 lobes of the cerebellum. Those help you with your balance and your hand-eye coordination. If your cerebellum is really strong, then you might be a good baseball player or a good soccer player. The diencephalon is kind of confusing. It's 3 structures. I'm going to show you a picture of that. And then the brainstem is composed of what's called the midbrain, the pons, and the medulla oblongata. This is where the brain connects to the spinal cord, and signals going back and forth from your sensory nerves and your motor control. When your brain tells your hand to move or to pick up a glass, those signals all travel down the brainstem via the pons and the medulla. And so here goes a picture of the diencephalon, and these are the 3 structures that compose the diencephalon. Number 1, you got the thalamus. That thing acts like a traffic cop, sort of. So when signals are coming up from the spinal cord, they go through the thalamus, and then the thalamus decides where in the brain those things need to go. So it's kind of like routing traffic. And then right below that is the hypothalamus. Get it? Because it's below the thalamus. Now the hypothalamus has a lot of responsibilities, not the least of which is helping to regulate your body temperature. The hypothalamus can be jacked up by several different things. Alcohol, like psychotropic drugs, things like marijuana, those all have an effect on the hypothalamus. This thing also is like in charge of routing for short-term memory. So if the hypothalamus is messed up, then you can have like blackout periods where you don't remember anything that happened. And people that get like really drunk, alcohol has a strong effect on the hypothalamus. If you get really profoundly intoxicated, and then like in the middle of the night, you'll wake up at like 3:30 in the morning and you're just like soaking with sweat. That's because your hypothalamus is trying to re-regulate your body temperature, but it's fallen down on the job because the alcohol has messed up its ability to do that. Now at the back of the brain, back of the thalamus is something called the epithalamus, and this is like right above the third ventricle of the ventricular system, whatever. Mostly the epithalamus is composed of the pineal gland, and that thing helps regulate your sleep. It produces a substance called melatonin, and when it gets dark outside, and if your pineal gland is functioning correctly, it's going to start generating melatonin. It's going to help you fall asleep. That's how it's supposed to work. Okay, don't really worry about this picture here too much. This is just showing like the rest of the structures of the limbic system. And also shows you the corpus callosum right here. That's an important thing to remember. I don't know why, but for some reason the registry likes to ask about the corpus callosum and the pons and the medulla. So you might see like a brain diagram, and then they're going to ask you to identify the different parts of it. It won't be, they're not going to point at this and say, well, what is that thing? You got to know that it's the olfactory bulb. No, they just want to know if you understand about gross anatomy of the human body. So I'm going to kind of help you guys with this. All right, now this is an actual human brain that somebody's taken a bandsaw to, and what they've done is they've cut right along the fissure between the left and right hemispheres of the brain. So we can see, here's the corpus callosum, and then we've got the pons. That's that little egg-shaped anterior structure right in front of the medulla oblongata, and then back here we've got the cerebellum. And this is that thalamus right here, and then down below that's the hypothalamus, and then tucked in behind here is that pineal gland. So this is what the things actually look like as opposed to the cartoons that we usually are seeing. Okay, now a little bit more. Up here in like I was talking a few minutes ago about the third ventricle, in the third and fourth ventricles, and I think in the lateral ventricles too, there are some special ependymal cells in there that are composed of a structure called the choroid plexus. That generates the CSF. Now the cerebrospinal fluid is supposed to like bathe the brain. The brain is suspended in this fluid, and the fluid and the brain have almost the same density, so in other words, like the brain is not heavier, so it doesn't sink to the bottom, and it's not lighter, so it doesn't float to the top. It's like neutral buoyancy in there, so that the brain doesn't have any pressure put on it normally. Because if the brain does have pressure put on it, you're going to have like a serious headache, and if the pressure continues, you're liable to start losing neurons. You don't want that. So inside the brain, inside the ventricles, we're generating CSF. It's going to flow through some little ducts and into the spinal canal, and it surrounds the spinal cord, so the spinal cord is also floating in fluid. And then along the way, this material, there's like little, almost like polyps, kind of cauliflower shaped, and you can only see these things if you look really close, but they're inside the spinal canal. And what those things do is they slowly reabsorb the cerebrospinal fluid. So the object is for the CSF to be created in the brain, come down the spinal canal, And then somewhere along the way, like down here in the lumbar area, it gets reabsorbed into the body. So the amount being created and the amount being absorbed is the same. So the amount of fluid in here stays static. Now, if that changes, you can have serious issues. We're going to talk about that later. Now, this is like a frontal aspect, like if we did a coronal slice across the skull. Okay, this is the compact bone. See how thick that bone is? Your cranium is pretty tough. It's almost like a built-in helmet. I mean, you know, if you get in a high-speed car crash, it's probably going to fail. But for day-to-day activities, it does a really good job of protecting your brain. You know, I don't think men were supposed to be traveling at 100 miles an hour. You know, we're just not really evolved for that. I guess maybe we will be someday. Anyways, down below the cranium, there's the epidural layer, okay, which is outside the dura mater. And then below that, we have the dura mater, the arachnoid space with these little hairs here that connect up to the pia mater, not really hairs, fibers. Okay, so right in this area here is where that CSF flows. And it's not very thick, but it doesn't have to be. And then the pia mater, as you remember, is in direct contact with the neural tissue of the brain. Okay, so we have this subarachnoid space that surrounds the brain and cushions it. And this up here, see this big black area? That's that venous sinus. You remember the superior sagittal sinus that we saw a picture of the other day? This is one of the major ways that blood gets out of the brain, you know, once it's been delivered by the arteries. Okay, so a little bit of a review. Whenever we talked about myelography, we went over the dura mater. The dura mater is that tough outer layer that surrounds all your major nervous tissue. Then below that is the arachnoid layer that has those little fibers. And then we have the pia mater that's in direct contact with the brain tissue itself or with the tissue of the spinal cord. And then we have those ventricles I was talking about. The CSF is created in the choroid plexus, and we have lateral ventricles, and those are big. And then the third and fourth ventricles are pretty small. And here's kind of how these things are laid out. Remember, these ventricles are, I guess they're kind of horn-shaped. That's how they're referred to anyways. We have the anterior, inferior, and posterior horns of the lateral ventricles, and then you have the body. That's the main part. And this whole thing is filled with cerebrospinal fluid. And then, okay, the lateral ventricles are pretty big. The fourth ventricle is pretty small, and the third ventricle is tucked right up here. It's fairly small also. Oh, down here below the fourth ventricle, there's like a passageway, and that leads to an area called the cisterna magna. It's right at it's just below the occipital area. And that was, you know, we talked about back in the day when they did cervical myelograms, sometimes the doctor would put the needle into that cisterna magna. You got to really know what you're doing to pull that off, and the chances for like seriously jacking up the patient are high. So they don't do that anymore. Okay, as y'all remember from our talk last time, anteriorly we have two internal carotid arteries. The carotid arteries enter the skull, and then they branch into the middle cerebral arteries and the anterior cerebral arteries. So there's your blood supply to the frontal portion of your brain. Now posteriorly we have the bilateral vertebral arteries. Remember, those come up and they merge to form the basilar artery that leads us to the circle of Willis. Circle of Willis is our collateral circulation that's going to hopefully save our lives in the event of a serious neck malfunction. And then the blood-brain barrier, that is, there's astrocytomas and other cells that basically serve the neuron. The neurons can't really do anything on their own except transmit electrical impulses and create new connections. They're very, very specialized. And they're also very delicate. They can get injured badly by poisons. So the blood-brain barrier is your body's attempt to keep poison out of your brain cells. And we'll talk a little bit more about that in class when next we meet. And then in the vertebral, in the spinal column, you've got intervertebral discs, which are consisting of like a tough annulus, which is a ring. It's really strong cartilage. And then in the middle of the annulus is the nucleus, and that's made out of like a bag of jello, and it serves as a shock absorber because, you know, we walk upright, and so our spine takes a lot of punishment. And here's another picture of the circle of Willis. Remember, the vertebral arteries lead to the basilar artery, and then that thing divides, and it sends out these posterior cerebral arteries, and we also have these posterior communicating arteries, anterior arteries, and then right up here is the anterior communicating artery. And then here's a picture of how the ring and the nucleus are put together. They're not perfectly round, ever. Okay, so with radiography, what can we see? Well, if there's like an obvious fracture of the brain, we can probably pick that up. But what about of brain tissue itself? Can we really see anything? Not without contrast injected. Now, if somebody's skull is like, you know, misshapen, if they've got like Paget's disease or something like that, then we can pick that up. We can see bony anomalies, but not soft tissue. That doesn't look all that good. Now, if you want to really get a look at somebody's brain, then MRI is the way to go. Magnetic resonance imaging. MRA is magnetic resonance angiography. We can actually see blood flow, even without contrast on board. But if there's gadolinium, it'll be even better. And then functional MRI is where we put a person in the magnet and we show them stimulus. You know, we show them pictures or expose them to sounds, whatever. And with MRI, you can actually see changes in the brain in real time. It's really interesting stuff. And then computed tomography. CT is our go-to modality for head and neck trauma. If somebody's been smashed in the face and the doctors really, if they're thinking, well, you know, it might be something there, might not, then sometimes they'll send them to us for x-rays. And so you'll do like mandible x-rays or lateral facial bone, stuff like that. But if the doctor's pretty sure that this person's been smacked, like, and they might be bleeding or whatever, they're just going to go ahead and send them to CT. For visualization of the facial bones and the base of the skull, nothing touches CT. It's definitely the best. Now, sonography can be used for some studies as long as the area of interest is relatively close to the surface. You might be able to use ultrasound to visualize like blood vessels, stuff like that. Now, nuclear medicine can be used, again, for functional studies of the brain, but the images, sometimes they're not all that definitive, but it can be used in conjunction with CT or MRI. That's called a fusion study, and sometimes nuclear medicine can spot things like gliomas, cancerous tumors in the brain. And then, of course, with vascular radiology, interventional, we can see a lot. A doctor can put a catheter up into the patient's brain and inject contrast, and they can do things like thrombectomies or coil placement. All kinds of stuff is possible. Okay, now, some diseases, because we are supposed to be talking about pathology. Hydrocephalus comes in a couple of different flavors. This is an overaccumulation of CSF. And when a baby is small, if they have hydrocephalus, remember the fontanelle, the different parts of the skull are not fused. They're connected by like cartilaginous tissue. So if there's a lot of pressure inside the brain, then that skull can actually start to grow and swell, and then the person winds up with an outsized head, permanently. It just looks really strange. When I was a kid, we, like if somebody had that condition, they were referred to as a waterhead, which I guess, was probably kind of cruel. But at the time, we didn't really think too much about it. Now, there's a couple of different ways hydrocephalus can work. Non-communicating. That means there is a blockage or a stricture somewhere in the spinal cord, and so the CSF is being created in the choroid plexus, but it can't get down to the lower end of the spinal cord or spinal canal where it's supposed to get reabsorbed. So we've got lots of fluid being produced, but it's not being reabsorbed as fast as it's being produced, so there's an overabundance of fluid, and it puts a lot of pressure on the brain tissue and the inside of the skull. Now, communicating hydrocephalus, in this case, there is a clear channel between the brain and the sacrum, so the CSF can get to where it needs to go, no problem. But for some reason, either the choroid plexus is working overtime and it's making tons of CSF, or the cells that are down inside the lower end of the spinal canal are not reabsorbing like they're supposed to. There's an imbalance. So we still got a problem. We've got an excessive accumulation of CSF. Now, this can be congenital, you can be born with it, and a lot of people that have conditions like spina bifida, they have a problem reabsorbing their CSF. It can also be acquired via disease process or just some kind of physical damage. CT and sonography are going to be able to show this pretty clearly, and the treatment is brain surgery. This is where the neurosurgeons come in, and they place a device called a shunt. And I don't know if you can really, okay, you see right over here, here's a shunt, and this is on a CT scan. So see all that beam hardening artifact that it's throwing out there? I mean, we can still see what's going on, but obviously this ventricle is way bigger than it needs to be, and it's put a lot of pressure on the patient's brain tissue. But with the help of the shunt, we can bleed off some of that excess cerebrospinal fluid. Now see this tube right here? The doctor's actually drilled a hole in the patient's skull and pushed that tube down into the ventricle, and there is a little pressure valve right there, and it is adjustable. And so what the neurosurgeon will do is they'll make that little valve, it's correctly calibrated so that when the pressure of the CSF gets high enough, the valve opens and then the fluid can pass down, and this little tube leads through the patient's body down into the peritoneal cavity, and the CSF can just be dumped out down there and the body will reabsorb it. Okay, so it's not going to be a danger to the brain anymore. Now you might notice, okay, anything odd about this patient's skull? Remember when I was telling you about how if there's pressure inside the skull at an early age, it can cause a misshapen skull. And this condition would be life-threatening. It would probably kill the patient if the neurosurgeon didn't place this device. Okay, some inflammatory processes. Everybody's heard of meningitis. You might have had meningitis, known somebody that had meningitis. Sometimes this thing can be deadly because people, they think they're sick. They know they're sick. But once this stuff, like bacteria, gets loose into the spinal canal, then it can go from bad to really bad very fast. So meningitis is one of those things that has to be caught quickly and treated quickly. Otherwise, it can certainly be life-threatening for the patient. Bacterial meningitis is the most common. What happens is, and this is no lie, people will get like a sinus infection, and they can have a sinus infection for long enough to where the infection can eat its way up into the brain case, because your sinuses are just right there. There's also viral meningitis. Now that's not as common, but it tends to have a pretty quick onset. And then chronic meningitis is typically caused by a fungal infection that somehow got into the spinal canal or into the tissues of the brain. A lot of times the fungal infection is secondary when patients have AIDS or HIV and they're severely immunocompromised, then they're more susceptible to fungal infections. Bacterial meningitis, a lot of times the way that's diagnosed is somebody has they wake up one morning and they got a splitting headache, or they wake up one morning and they're just crazy because there's so much pressure on the brain that it actually causes personality changes, and it can cause violent outbursts. I'll tell you a story about that someday. Treatment is with antibiotic therapy, and like I said, it has to be tackled fast because this can get out of control very, very quickly. Encephalitis is just a generic term for inflammation of the brain tissue. It could be idiopathic, it could be bacterial in nature. We don't really know until we take a sample. It's usually a virus, and when your brain tissue becomes inflamed, that doesn't feel too good. And like I said, not only can it cause pain, all kinds of like gait disturbances, ataxia, stuff like that, severe headaches, just general malaise, feeling bad. Diagnosis. We're going to see this on an MRI, probably not on an X-ray. And treatment can be antiviral medications, but it has to be treated quickly because we're talking about brain tissue here, and inflammation of the brain tissue causes increased pressure inside the brain case, and this can cause your central nervous system to just call it a day. Certainly can be fatal. All right, some vascular disease. We're going to talk more about this when we do our trauma unit, but for right now we're just mostly talking about cerebrovascular accident, aka the stroke. There's a couple different kinds of stroke you can have, well, really more than that, but in general, either your stroke is ischemic, there's been a blockage of an artery, and so now an area of the brain's not getting as much nutrition as it needs, or it could be a hemorrhagic. Now, hemorrhagic stroke is where you have a blood vessel in the brain that just breaks, and so all of a sudden the blood is going out into the surrounding tissue instead of into the capillary beds, so that tissue that's supposed to be getting infused by that particular artery is now starving. This can have some seriously deleterious effects. This can be like some people have a stroke, especially a hemorrhagic stroke, and they just die right there. They don't make it to the hospital. If they do make it to the hospital, then it's possible that the doctor can save their life, but they may wind up being paralyzed on one side of their body for the rest of their life. A lot of times people don't make 100% recovery from a stroke. Stroke's going to show up on a CT, maybe not right off the bat. Now, if it's a hemorrhagic stroke and we do a CT scan of the head with contrast, then we might see some spillage out into the surrounding tissue. But basically what you have to do is you have to catch this thing with CT I'm talking about after the blood has had a chance to congeal, and then we'll be able to see it contrasted against the normal brain tissue, and that's how the doctor can spot hemorrhagic stroke. MRI is going to reveal it right off the bat. There's going to be no issue there. The problem with MRI is, say you're working at a facility that you only have a magnet available during the day, right? So you have to call in an MRI tech, and then once they get there, it takes them 30 minutes to acquire the images. Well, meanwhile, your patient's sitting there stroking out. Their time is of the essence, in other words. Carotid sonography and MRA, a lot of times that can be useful in diagnosis. If you have, if the bleed is close to the surface of the brain, they can probably spot that. Excuse me. Now, here is a picture. This is a CT scan. And this is, you can see, okay, well, there's a lot of darkness out here that shouldn't be. Okay, that is an area of reduced density because it's had its blood supply cut off. Okay, so this is from an occluded anterior cerebral artery and middle cerebral artery. And the way we know that is because some doctor went in there and looked and they found the blockages. But this is what an ischemic stroke might look like a patient comes in for a CT scan status post-stroke. Now, here is hemorrhagic stroke, and this is another CT scan, but this time with contrast, showing spillage right here. So, that there shouldn't be contrast leaking out into the surrounding tissues. If there is, then that's positive for hemorrhagic stroke. Now, if somebody's got this kind of condition going on, you cannot give them blood thinners. If they've got an ischemic stroke, then the doctor can give them blood thinners and hopefully get the blood flow restored to that area of the brain before the damage becomes too great. Because it turns out these neurons, they need nourished constantly. Okay, now I'm going to show you guys brain AVM. This is just a YouTube video that I got, mayoclinic.org. So if you want to, you can go on YouTube and look for the arteriovenous malformation. It's pretty fascinating stuff, I think. We're not going to look at that video right this minute because I want to go ahead and get on with the rest of this. Neoplastic disease. This is like benign or cancerous tumors. These are new growths inside the brain. Now, primary tumors of the brain only account for about 10% of cancer deaths. Brain cancer is not one of those things that happens all that often, but when it does, it can be absolutely disastrous. So, a primary brain cancer is one that originated in the brain tissue. A metastatic brain cancer is one that originated someplace else. Could have been in the lungs, could have been in the colon, the liver, whatever. And then it migrated to the brain and found a place that it could take hold and started growing. Couple things to consider: where the neoplasm is and the age of the patient. Young people don't typically have metastatic cancer. That's the kind of thing that takes years to develop. And we classify brain tumors by a couple different ways. Number one, the site. Where the heck is this thing? Is it in the cerebellum? Is it in the cerebral area? And then the other thing is histologic composition. Most of these tumors are going to be gliomas. They're going to be like astrocytomas, medulloblastomas, things like that. But then there's also non-gliomal tumors. Those could be tumors of the actual tissue, like a pituitary adenoma. Gliomas are most common. About 45% of brain tumors are gliomas. Nobody really knows why these things start malfunctioning and forming cancerous tissue. They just do sometimes. And I don't know that there's any like common thread that doctors have discovered. Typically these things are intracranial, they're inside the cranium, and on an MRI they look like an increase, like an area of swelling, basically. And on CT, typically gliomas look like a decreased area of density. In other words, the surrounding brain tissue is lighter colored than the glioma, and it stands out as like a dark lump. Okay, and sometimes people have headaches, vomiting, nausea, vertigo, dizziness, blurry vision, depending on where the tumor is happening. If it's back in the occipital area, it's probably going to affect your vision. If it's in the temporal area, it could affect your hearing or your sense of balance. Astrocytomas make up 1/3 of all gliomas. An astrocyte is a specialized cell. What it's designed to do is act as an intermediary between the capillaries and the neural cells. It's the main part of the blood-brain barrier that we were talking about. So what an astrocyte does is it services its neurons by collecting oxygen and nutrients from the blood and then passing them along to the neurons, and then from the neurons it takes their waste products and passes them back to the bloodstream. So there's no direct connection between the capillaries and the neurons. Okay, so, and the way this thing works, supposed to be, the astrocyte, whenever it sees something that it thinks might be toxic to its brain cells, then it's not going to pass that along. But if it's something that it thinks are good for its brain cells, then it will hand them. It'll give them oxygen and glucose primarily. Hopefully that, okay. Now, glioblastoma multiforme, this is a highly malignant form of, the glioblasts are undifferentiated cells. They could be astrocytes or, what is the other thing, those oligocytes. But when they're in the, like the stem cell stage, they could develop into whatever the body needs. These things are more mitotic and therefore more aggressive. The oligodendrogliomas, these are slow-growing tumors made of oligocytes, and they tend to be not necessarily malign, but they can wind up taking up space inside the brain case, and when they do, they put pressure on the brain, and that can wind up killing the patient too. So just because a tumor is benign doesn't mean it's completely harmless. Ependymomas, these are tumors that are made out of ependymal cells, and these usually arise in the fourth ventricle of the brain. I'm not sure why. But for all these things, treatment is either surgery, to like physically remove this thing, radiation therapy, which also includes the gamma knife. We'll talk about that whenever we do our radiation therapy stuff. And chemotherapy. Basically, if you're going to give somebody chemo, you're trying to poison the malignant tissue without killing the good tissue. Prognosis is not all that good. About 25% of people that get diagnosed with these gliomas, only about 25% survive after 2 years. So even with treatment, this stuff is deadly. And here's a pic, and you can see why. I mean, golly, okay, here we go. We got invasive tissue in the brain taking up space and putting the squeeze on the surrounding brain tissue. So this can't go on for too long, right? And this is a very large glioma. Medulloblastoma. Now, medullo, that implies the spinal cord, right? So medulloblastoma is typically going to originate in the spinal cord, but it can quickly migrate into the cerebellum. These things are highly malignant. They're like a high-grade tumor. Now, what'll happen is people wind up getting like ataxic. They can't walk, or they're off balance. They don't have any hand-eye coordination. They're dropping stuff. They're dizzy. They're falling down. It's like, what in the heck's wrong with this guy? Well, his cerebellum is getting compromised by cancer. Treatment is by surgery and radiation, and 5-year survival rate for these things is about 50%. So not one of the things you want to see on your chart is a medulloblastoma. And here's, whenever we do an MRI, and we've got, this is a sagittal MRI reconstruction, and you can see, okay, well that shouldn't ought to be there. And then once the doctor's injected, or the technologist has injected some gadolinium and rescans, then you can see, okay, well here's some area that are suspicious because they're different than the surrounding tissue. And I'm sure that patient was having a lot of symptomology, a lot of symptoms. Okay, meningiomas, as its name implies, this is a tumor that originates in the meninges, typically the arachnoid layer. Most commonly found in 40 to 60-year-old people, and it actually may show up on a regular x-ray as an area of increased vascularity. In other words, it's got a lot of blood vessels grown that shouldn't be in that area. It's just, it looks abnormal. Now, with contrast on board, a CT scan is going to show it much more clearly. And treatment, okay, either the doctor can go in there and remove it directly, or they can use the gamma knife, which is like a really, really strong but thin beam of radiation. It's like 20, maybe 30 mega electron volts in an extremely small stream. And it can be used to take out cancers that are small and in hard to reach areas. And here's another image of a meningioma. And as you might imagine, since it is originating in the meninges, these are always close to the surface of the brain. But as they grow, they can take up a lot of space and wind up causing all kinds of difficulties for the patient. You don't want anything in your brain case except your brain. Now, pituitary adenomas. These things are typically benign, although they can take up space and they can jack up the pituitary gland and make it either produce too much growth hormone or not enough. This accounts for about 50% of intracranial, inside the cranium, tumors, and typically goes along with enlargement and erosion of the sella turcica, because that's where the pituitary gland sits. Now, this thing may actually displace the Sylvan triangle, so that could show up on a like if we're doing interventional, if we have contrast injected into the patient and that Sylvan triangle that we looked at is not where it's supposed to be, then that can mean that there's something growing there that's taking up space. CT or MRI is the best way to diagnose these things, and then treatment is by surgical removal or the gamma knife like we were talking about. Because look where this thing is located. Okay, this is from a, think of like an AP. This is looking from the frontal aspect. And here this tumor is. See, it's down, it's below all this brain tissue. How are you supposed to get to that thing? And here it is on the lateral reconstruction. That's, oh, and check this out. You see this big black area right here? That is not a ventricle of the brain. That's the sella turcica. On an MRI, bone doesn't really show up, especially cortical bone. It's like, okay, well, what the heck? Where'd my sella turcica go? It's still there, but MRI can't really visualize it all that well. Okay, craniopharyngioma. You might imagine this is a tumor that arises from the back of the nasopharynx and grows into the brain. These things are typically found in kids, and they can cause erosion of the sella turcica. And on a CT scan, this is going to be like a mass that sits right above the sella turcica, which is what suprasellar means. And again, surgery or radiation therapy is what's required to get rid of this thing. Now, some tumors attack the sheath cells. You know, there's like a myelin sheath that covers your neurons, so, and it acts like an insulator. Okay, so if there's a like a tumor that is involving those sheaths, then what it can cause is it's kind of like a short circuit. You know, you can imagine if you took an electric cord and you started digging away at the insulation, what's going to happen? Well, nothing good. You know, you're going to have short circuits and fires and all kinds of problems. Same kind of thing in the body. Okay, if these nerve sheaths get damaged by tumorous tissue, then it can cause like all kinds of visual, auditory, motor disturbances, depending on which nerve sheaths are getting affected. So it could be the ear, the acoustic nerves. In that case, it would be an acoustic neuroma or a neurolymoma. Now, metastatic disease. About 10% of brain tumors actually came from someplace else. These things can be solitary, or there can be multiple, you know, like if there's a bunch of different cancer cells that arrive in the brain and take root in different places, you can have like diffuse cancer in the brain. Normally, these things arise from lung cancer. I'm not 100% sure why. They can also come from breast cancer, bronchogenic carcinoma, which is AKA lung cancer, and malignant melanoma. So if you've got skin cancer, that can actually migrate to the brain and wind up causing big problems. I know you think, well, melanoma, that's no big deal. I'll just get this little patch of skin cut off. Okay, if you catch it fast enough, you can do that. But if melanoma is let to sit there and develop, then it can migrate and cause problems. Neurologic symptoms. Lack of hand-eye coordination, visual disturbances, a lot of different symptomology, you know, partial paralysis maybe. And this is diagnosed definitively with CT and MRI. And also if we go in there and get a chunk of the material and we find out that it's cancerous for sure. Now, once somebody has metastatic cancer, what can we do? Well, surgery possibly, radiation therapy possibly, radiosurgery, aka gamma knife. And the prognosis depends on the severity. If there's like 100 nodules in your brain, then there's probably nothing much the doctors can do about that. But if there's just one or two, maybe they can you know, get those out of there. That would be great. Now, tumors of the spinal cord, not as common as primary brain tumors, but they do happen. Now, if the tumor grows outside the dura mater, then it's considered extradural. If it's inside, then it's considered intradural. And intradural can take a couple different forms. Extramedullary means, okay, so it's inside the dura mater, but it's outside the spinal cord proper. Okay, so those include meningiomas and neurofibromas. Now, if the tumor is growing inside the spinal cord itself, those are typically either astrocytomas, composed of astrocytes, or ependymomas composed of ependymal cells. And ependymal cells, by the way, those are the cells that make up the pia mater. So those are the cells that are actually in touch with the brain tissue. And ependymal cells come in several different styles. Some are just coating the brain. Some are in charge of reabsorbing CSF. Some are in charge of producing CSF. And some of the ependymal cells actually have like cilia, to help keep the CSF moving. Kind of fascinating stuff. And I've showed you guys this picture before, I think. This is a large tumor that is compressing the spinal cord. And this can cause ataxia, pain, weakness, lack of motor control. This may show up on a myelogram, actually. Now, for definitive diagnosis, we really need an MRI. MRI is really good. We could also spot this thing on a PET scan. But on a PET scan, we're going to see, okay, well, it looks like there's a tumor there, but we don't have a really good idea about the actual size and shape of it. MRI, you'll see it very clearly. Now, for an extradural tumor, it's possible to do a myelogram and then send the patient to CT. That could show it up also. And some patients are not really a candidate for MRI due to metallic implants, pacemaker, for example. If you have a pacemaker, you can't get in the magnet. That's not going to work. So then we have to figure out some other way to do this imaging. And treatment, as always, is surgery to get rid of the thing, or radiation therapy to kill it with high-powered X-ray. Now, are these different pathologies additive or subtractive? Well, most are neither, because remember, the brain tissue is very close in composition to the CSF, which in turn is close in composition to water. These things are all about the same attenuation. So if there's blood or anything like that, it's going to be really hard to spot, except for spondylosis. Spondylosis is considered subtractive because it involves destruction of bony tissue. Most commonly vertebral bodies that are getting osteoporotic or arthritic. All right, here goes another video that we will watch in class possibly, provided of course that it's still there. Or you guys can go and watch it on your own, but I'm not going to include it as part of this presentation. All right, so as always, thank you very much for your kind attention. I appreciate it. And I'm going to post this video so that y'all can look at it at your leisure. And we're also going to go over this material in class, time permitting. All right, y'all, have a good one.